Thank you very much for the introduction, and thank you very much for the invitation. I'm glad to be here again. The topic today is who do I pick for primary pedal access? Nothing to disclose. The question is, should we perform primary pedal access? Why I do it, how I do it, and then who I do it. So let's start why I do it. So problem for the femoral access is, this is an old slide. I think all relate to the bleeding severity. If you have no bleeding, I think the outcomes are really good. You have the severe bleeding, blood transfusion, etc., and you don't have a good outcome. And this slide you see multiple times in a conference. It's a huge pseudoaneurysm, and patient have ecchymosis from the femoral puncture. Usually it won't causing anything, but the problem is when you do private practice, this patient will come back to see you, and this is what they remember. It's not how good you do to the patient. The claudication, critical limb ischemia is resolved, but they see the ecchymosis and they blame on you. And this is a retroperitoneal bleeding and life-threatening situation from the femoral access. Closing device is not decrease the femoral complication, and this is a per-course complication. You can see when you do it perfectly, and this artery close, and the patient have a bad outcome. And this is an angioceal complication, one of my early experience. Patient deploy angioceal, and this angioceal, the plate is still inside and still causing obstruction, and this not resolved in few months. So the question is, how we can avoid this femoral access complication when we do peripheral intervention. So from the study of a transradial cath to coronary cath, we know transradial is a good thing to do. Okay, we can avoid the femoral complication. So, but the problem is a transradial approach to PAD. This is many problems. One is the technical challenge. The sheet we're using in the transradial is much bigger than the sheet when we do it in the coronary. And we can causing spasm, the tortuosity, subclavian tortuosity, everything can be bad, can be very difficult. It is a challenge. And also from the radial going down into the femoral iliac tibial artery, if you are not careful, sometimes the guide wire will go into the abdominal vessel and you perforate. It happened before. Okay, it happened in the mesenteric artery, renal artery, etc., etc. So very careful when you do the radial going down into the femoral artery. It will transverse the intra-abdominal vessel. Most important is we still don't have a dedicated hardware. We need a long sheet, long guiding catheter, long guide wire, long stand shaft, etc., to going down from the radial all the way to the femoral and then tibial vessel. And if you have very tall patient, that's a big challenge. Nowadays, the equipment is much better than before. We do have the long shaft, but sometimes they were not enough to reach it down the distal vessel. So we're thinking, how about the retrograde approach? From the pedal up, going backward, so the length will be less. Okay, just using the same equipment, we can overcome the problem of the equipment problem. So this is a retrograde approach. And usually we do that facilitate revascularization. When we fail antegrade down, okay, and we can go back to retrograde, and there's a couple of reasons. It's easier to go down retrograde because the pressure is usually lower down in the retrograde segment, and there's a less fibrotic cap, less calcification on that retrograde thing. And easier to, when you retrograde, when you go into small lumen, going up to the big lumen, easier to re-entry into a big lumen. There's a many study for the feasibility and safety of the retrograde pedo, pi-minute pedo approach, and it's already well established. Okay, the complication rate low and the successful rate quite high. Okay, the way we do that, okay, transpural puncture, we're using ultrasound, which is a very, very recommended. You should know what you're doing. Palpation, probably not a good idea because this patient uses no pulse. And we can do fluoroscopic guidance and geographic row mapping. And in terms of the fluoroscopic V-side, the peroneal artery puncture is very helpful in situation. In terms of ultrasound guidance, this is the short axis. Okay, you can go in, and you can do long axis too. This is a long axis puncture. So either way is a prefer, not a problem. And angiographic guidance, you can do from the radial artery going down, inject it, or femoral artery going down, inject it, and you can see, you can puncture angiographic. And this is how we do the V-side peroneal artery puncture. Peroneal arteries are lying between here, and you can puncture right in that situation. And after you get the ultrasound guided micropuncture, we're using the same as a radial technique, put the vasodilator cocktail and heparinize this patient. Just give some quick case example. When we do the pi-minute pedo approach single axis, we can go up, okay, access a pedo artery, and you can see the SFA CTO here, and loaded with the 018 glide wire, and we're using 4 French vertebral catheter, and go up, and this one re-entry into the SFA, very easy, and you can do everything from the pedo sheet, standing, balloon, and with a good result. Another case example is if we can do pi-minute pedo at the secondary radial axis for the CTO, and we put a sheet in the pedo, AT sheet, and we measure the pressure all the time now. The pressure, you can see a flat line. Same thing as a CTO SF AT. And the antegrade radial artery, you can see there's a CTO SFA. And this one using car technique, and we use antegrade glide wire, 035 glide wire going down, and retrograde wire and the balloon. And this is a radial pedo cot. Externalize the guide wire from the pedo sheet, and everything's going up, backward, retrograde backward, standing, balloon, everything there. Okay, and this is a final angiogram, SFA, AT, all revascularized. And the pressure, we can see the increase of pressure from flat line, and you can see a good pressure from the pedo pressure. Sometimes we don't see any distal runoff at all, and we can do it from the antegrade radial guidance going downward, and you can see the arteries are very faint distal, and we can see the peroneal artery just barely visualized, and you can puncture using angiographic guidance, and also you can using revascularization, the same technique, car technique, and the pressure increase and that. The last one, I want to show the complication for the femoral access. This patient have an Impala put on, rotor left main bifurcation standing. You can see a lot of calcium in the common femoral artery. Okay, and PCOS was done at that time. And after the successful coronary left main standing, DK crush, but the failed PERCOS, okay, the suture broke. So we're using the left radial tamponade. Okay, unfortunately, the guide wire cannot go down into the SFA, and it's just a balloon tamponade in the iliac artery. And the patient have even though despite compression, angio-seal, and patients, you can see injection, you can show some slow flow, okay? But you can see the flow into the common femoral artery, and 45 minutes later, patient have an ischemic limb, and then I need a final slide here. Okay. Okay. And we go pedal up, and then balloon easy going up, and then you can see the blood flow is a very bliss after we balloon the dissection plane of the femoral dissection. Okay, so that is my last slide. Who do I pick for the primary pedal access? Avoid femoral complication, definitely. Okay, in patient high bleeding risk, obesity, taking blood thinner, this patient, definitely I like to do that. And the outpatient setting, right now the OBL, a lot of people doing OBL, you want patient go home, okay, safely. I think the pedal access is very important, and the patient satisfactory and staff satisfaction important. And if you have femoral complication, they call you at nighttime, and I think the pedal access can be very easy to help you save the patient. Which anatomy I would do it? Iliac, probably not. SCTO, SFA, POP, tibial, probably yes. More than 6 French, probably no. Infection area, definitely no. And you cannot put any filter device in the pedal. And I think that's it. Thank you very much.